it's Kayoung here, and for those of you who are watching my video for the first time, hi, I'm Kayoung and I'm a third-year medical student in Canada. I just finished my 2-week anesthesia rotation and I just wanted to talk about how it went, what my day looked like as a med student, and what I like about it. So let's start with what my day looked like. I normally start my day around 7 a.m. and the first thing I do is check the OR slate. I already know which anesthesiologist I'm working with. I look up their name and it says which OR I'm in for which case and the patient's name as well. So I go into the OR and see if the anesthesiologist is there, and if they are, I check in and I introduce myself, and if not, I write my name on the board so that the nurses know who I am and what level of training I'm in, and I check if the anesthesia cart is already set up. So that consists of suction, oxygen mask, and things you need for intubation like the endotracheal tube and laryngoscope. And then I go to the pre-op area to introduce myself to the patient, and if the pre-op anesthesia record hasn't been filled out, I do that part by asking the patient a few questions. I first get them to tell me what operation they're having in their own words. This helps me confirm that I'm with the right patient for the right procedure. Then I ask if they have had any previous operations, if they were under any anesthetics, if they had any adverse reactions or complications with the anesthetics. Then I ask about their smoking history, alcohol or drug use history, any respiratory conditions, and I also ask about any cardiovascular conditions such as hypertension, chest pain, and if there's any history of heart attacks and so on. I ask about their exercise tolerance, if they ever get short of breath after walking a few blocks, and if they have a history of acid reflux, to assess for aspiration risk, any allergies or any medications they're taking, and other medical concerns. And then I move on to the airway exam, so I get them to pull down the mask and open their mouth as wide as they can, and I'm assessing their Mallampati score, which is a grading system that helps us determine how easy or hard it would be to intubate the patient, as well as assessing their obstructive sleep apnea risk. So it goes from grade 1 to 4, from full visualization of their soft palate to not being able to visualize much at all. Then I get them to extend their neck, which assesses neck movement and their thyromental distance. So these are all considerations that we keep in mind when intubating the patient. After I finish the assessment, I come back to the OR and I report back to the anesthesiologist, kind of summarizing their medical history and anything that I want to highlight. When the patient is brought into the OR, I help put the monitors on, such as the oxygen saturation probe, the blood pressure cuff, and the ECG lead. And then I put on the oxygen mask when the anesthesiologist is administering the induction agents. When the patient drifts off to sleep, they stop breathing. So this is when I start bag masking. Bag mask ventilation is a life-saving skill, so everyone told me that it's even more important than learning how to intubate. Just to illustrate how it works, you use the EC technique, so these 3 fingers are supposed to represent E and C. So you're holding down the mask with the C portion, your thumb and index finger, and with your 3 other fingers you are propping the chin up to keep the airway open. The way I was taught in school is to put my pinky behind the angle of the jaw, but yesterday my staff told me to use my middle finger or 4th finger because they're stronger than my pinky, which makes sense. So I think it comes down to like staff preference to a certain point, but this makes sense to use your stronger fingers. So maybe there needs to be a small change in the way we're taught in school. After giving a few breaths of 100% oxygen, then we move on to intubation. So I use the laryngoscope to visualize the vocal cords, and once I can, I put the endotracheal tube in, and we put a metal rod called stylet. Once I'm slightly past the vocal cords, I ask the nurse to pull out the stylet so that I can advance further, and there's a little inflatable cuff at the end of the tube, so once you're past the vocal cord, you inflate it so that it keeps the tube in place. So then I connect the tube to the ventilator so that oxygen can be administered, and I secure the tube in place by using tape. Then once the surgery team starts, I help with draping. So this summarizes the general process for adult procedures. There are variations depending on the patient you're working with, especially with pediatric and obstetric populations. There are special considerations which makes it super interesting, but I won't go into the nitty-gritty details. I didn't know too much about anesthesiology before starting this rotation, but I learned so much in the last 2 weeks by actively getting involved in the cases and talking to preceptors. What was really nice about this rotation is that during the case, when we were just monitoring vitals and administering medications here and there was lots of downtime where I can really ask my staff about what they like about the specialty, what they don't like, and what their life looks like outside the hospital. On my first day of anesthesia, my preceptor asked me what my hobbies were, and I was just so touched by that because no preceptor has asked me that before. Just the fact that they wanted to get to know me more as a person really touched me, and I got to ask about their hobbies too. So it's really nice to know that there's a good work-life balance in this specialty. And another thing I really appreciated is during the downtime, I had lots of opportunities to ask questions and go over some of the underlying physiology behind what we do in anesthesia, such as blood pressure monitoring and blood pressure control, different types of anesthetics, and what we need to consider in specific populations. And even yesterday, I had one-on-one teaching on topics like chronic kidney disease and arterial blood gases. So it was nice to revisit the topics I learned in my preclinical years and apply them in the context of anesthesia. I think anesthesia is such a good specialty if you like being in the OR, and I've heard people say that if OR is your favorite place in the hospital, that you should do anesthesia, whereas if the OR is your favorite place on earth, then do surgery. And my understanding of what an anesthesiologist does was very limited when I didn't know much about this specialty, so I just thought it had to do with putting patients to sleep and making sure that they don't experience any pain. But there's actually a wide variety of things you do as an anesthesiologist. You can even get involved in ICU work. In my last cardiac surgery rotation, the people who were running the cardiac surgery ICU were all cardiac anesthesiologists. I think that what an anesthesiologist does is kind of like a spectrum. So they're the ones responding to critical emergency situations when a patient is unstable. On the other hand, when they are stable, it's quite peaceful. So you kind of have both of these ends of the spectrum in the scope of work. I got much more comfortable with bag mask ventilations, which is a life-saving skill in emergency situations. I also finally got the hang of putting in the IV in the right place without blood leaking, so I'm really proud of myself, and I felt much better about my intubation skills by the end of this rotation. So this is all I wanted to share in this video. If you have any questions, please leave them in the comments below. If you're also a med student like me, or if you're a resident in anesthesiology, please let me know what your thoughts are. I would love to know. So I will end my video here, and my next rotation is plastic surgery, and I'm really excited about it, so stay tuned for that video. See you guys!